So, congenital pseudoarthrosis of tibia, also known as CPT, it affects mostly the young children. Initially, it was believed that if you diagnose early, so the treatment varies, but sometimes the diagnosis is late presentable. So, in kind of 4 to 12 years, till then the fracture is developed. That's why the treatment plan varies and the prognosis outcome varies. So it's basically the pathology. If we go, the pathology is basically the fibrogenic tissues developed, and that's why the osteogenic activity at the site is less, and osteoclastic activity increases. That's why the bone resorption occurs, and the medullary cavity is most affected than outer cortex. So it mostly affects the young children, most common in birth to 4 years, early presentation. And
so if it was, for example, detected early on before a fracture occurs,
so we can manage conservatively plaster, and later on we can present the reoccurrence of fracture, everything. But if once the fracture is developed or cyst is developed, then the treatment is mostly surgical.
Okay. Anyone who would say what the surgical treatment for this is?
So, like said, I would like to add some of the points. Sir said, it is very rare. Like it happens in 1.5 lakh children, and it is commonly associated with two common congenital deformities like neurofibromatosis 1 and fibrous dysplasia, of which 75% is NF1 and only 15 to 20% is fibrous dysplasia association.
So that's an interesting observation. So if such a predominance of neurofibromatosis, correct me if I am wrong, but neurofibromatosis is a condition which can actually be widespread.
Yeah.
So is it a localized phenomenon or is it part of a wider syndrome?
It is part of a wider syndrome as mentioned in the literature, sir. Plus, what we have to be careful is like look for the other features of NF1 like Café spots, then erythema nodosum, and like neurofibromas under the skin, and yes, Lish nodules in the iris, which doesn't actually affect the vision, but it can be seen on ophthalmologic examination.
Blue sclera basically, just like in osteogenesis imperfecta mein hota hai.
Then, sir, the presentation varies. Usually, by birth, they are not presented and showing any bowing as such. But with the progression of age, before the patient completes 10 years, the clinical presentation develops, and we can diagnose the patient before 10 years. Like sir said, if the patient doesn't have a pseudoarthrosis, just the bowing is present without any fracture or pseudoarthrosis, we can just go for bracing, sir.
With bracing, okay.
Yes, sir.
Before the fracture agar if it presents.
Yes. And in case there's a fracture or there's clear-cut pseudoarthrosis, then we have to address it surgically. Then for surgical management, sir, there are two main treatments mentioned here. One, one of our colleague had shared yesterday, that we can do for a circular Lizaro frame by resection of the site of the pseudoarthrosis, then docking of the two sites, and then gradual lengthening of them. But since it is a tedious procedure and not every surgeon is familiar with it, there's another procedure mentioned in the literature, that is again resection of the pseudoarthrosis site, then followed by intramedullary nailing and stabilizing. Some people suggest we should stabilize the ankle joint and the distal joints as well, along with the distal fragment of the tibia.
You mean impale it through and through?
Yes. Problem develops in adjacent joints also. Sometimes the deformity is such that the malrotation of ankle or knee also be there. That's why we have to get X-ray of adjacent joints also.
So then my question is, when you say stabilize the ankle, you mean to say a nail which was put through the tibia will be long enough to go through the talus into the calcaneum? What do you mean by stabilize? When you say stabilize the ankle, do you have a clarity on that?
In some literature, sir, they have done articles which show that they have put a rod through the talus into the calcaneum, sir. They do have done that.
And why is this so? Why is it suggested that you do that?
Like sir said, like sir, the surrounding joints as well are affected and they don't have the stability. Another theory would be like because of the bowing at the distal one third of tibia, the normal anatomy is varied, so they don't develop the surrounding soft tissue stability around the ankle joints as well.
So I would have thought maybe they are talking about stabilizing at this young age. Although I presume they don't mean fuse it forever. It's just that you temporarily put a rod through it. Perhaps it is because when you correct a anterior bow of the tibia, the posterior gastrocsoleus complex and the tendoachilles becomes relatively tight and it will pull the foot into equinus. So it is perhaps to prevent that equinus deformity from developing that they might be suggesting to stabilize rather than because pseudoarthrosis of the tibia from my student days that I read on this and whatever little bit of work I did in my career on this condition, which I have treated perhaps 3 in a very early part of my career. And at that point in time, I was given to understand that it is a localized phenomenon. There is some pseudofibrotic, some sort of a neurofibrotic element at that site where the bone gives way and then it doesn't heal. And even if it heals, the quality of healing is so poor that it goes into refracture again and again. So we have this case which we have put up on our group. What would be your suggestion be based on this? Do you want to make a comment on it? What would be your suggestion?
Just to quickly summarize, the treatment options available, the treatment options available are one is nailing, telescopic nailing. Other is using Elizarov to take that segment of bone out, fix it and lengthen it. And anything else?
That is amputation. Vascularized bone graft and the later, after most trials failed, then amputation is the amputation. That's right.
Yeah, I mean in those cases where repeated fractures and because it is usually quite near the ankle joint. So to stabilize it is also not a very easy job. For example, if you put a nail through, and usually at this young age now we have this extending or extendable nails, but otherwise thick rush pins is what we used to use. Thick rush pins, from near the tibial tuberosity, वहाँ से नीचे उतार देते थे. So one of the other reasons for going through the ankle might have also been to get a good hold of this thing. So in this case that we are referring to, what do you suggest should we be doing?
Sir, some cases they have added a additional plating as well to support the nail. So like in this case, we have seen the deformity is quite distal and there's a clear cut loss of cortical continuity as well, suggesting of a fracture.
It's on our OPD group, right? Yes. So allow us to open academic PhD.
So we can go ahead with the resection of the pseudoarthrosis site and then stabilizing it with a intramedullary nail. I think we'll have a good purchase in the distal fragment as well, so it is not that distal in this case. Yes,
I think the nailing is better in this option. First,
plus we can provide a supplement plate.
Derotation plate. The plate would be more about derotation rather than anything else. What about the fibula?
We need to resect the fibula fragment as well.
I think so. Otherwise, it will not allow us to straighten it out. And there's in the lateral view, you can see there is a distinct cyst. There is a distinct cyst on the lateral view. So there is a varus and flexion deformity.
Sir, it was type 3, then converted to type 4.
And what are those different types? Are you familiar with the gradation?
3 classification mostly used, sir. One is Anderson, and Boyd and Crawford.
Say that again.
Boyd, Crawford, and Anderson.
So there are 3 different classifications given to this condition. One called the Boyd classification, Crawford, and Anderson.
So Anderson mostly divided into 3: dysplastic, sclerotic, and cystic. 3 he gave the classification according to.
Which one do you think is this case?
But it's according to Anderson we cannot classify, said this. It's sclerosed plus cystic both.
Both components.
So most commonly used is Crawford.
And what is the Crawford classification?
It has four subgroups. In number one is that medulla is intact at the pseudoarthrosis site. The medulla is intact, but the cortex has thickening of cortex has occurred. Second classification is that medulla is also affected. Medulla thinning is out.
Hourglass constriction.
Hourglass constriction.
Which is most common type and most highly risky.
And risky in the sense of resistance to treatment.
Third is cystic lesion is there, and fourth is complete pseudoarthrosis is present along with the fibula. That
And fourth also called idiopathic. There is no reason.
So here I think as per Crawford, which one would you,
it's type 4.
means complete
Yeah,
pseudoarthrosis?
complete pseudoarthrosis along with the fibula dysplastic.
Yeah, there's no doubt that the fibula is quite bent actually.
Yes, sir.
You know, so yeah, and if you look at the zoomed in view of the lateral view, the lateral view seems to give you a much more sort of clarity. Okay. So what do you propose we should plan for this case? Can you find out whether we have a telescoping rod available at?
Yeah,
It's available. So may I suggest call the vendor to demonstrate it to us, as a proper clarity of how it is working. And I think we will need to excise almost 1.5 inches
Yeah.
of the two ends, maybe even
shortening of
there will be considerable shortening, maybe even 2 inches.
Yeah.
But I think if at all this kid is going to be, because I think he's, what is his age?
8 years.
8 years, yeah. So if at all this kid is going to be treated for limb length discrepancy, it should be done once he reaches maturity. Would I be right in thinking that pseudoarthrosis of the tibia, for some strange reason, doesn't seem to bother once they reach puberty? After that,
Yes, it's progressive till skeletal maturity.
and then once it is skeletal, the deformity stops, and if the limb has been preserved and kept aligned till then in later life they seem to do quite well.
Yes.
Why do you think the sclera looks blue? Ashay?
Usually, when an individual has collagen issues, the sclera, the collagen under the sclera is thinned out, and the veins behind or under that collagen layer are visible more to the outside.
Exactly. So it's the whiteness that you see is the thinning out of that white layer, which allows the almost blue-black colored layer of the inner part of your eyeball. I think it's called the chorea or something, choreana. And that layer, which is blue-black, when sort of the color comes through the thinned out white sclera because of the collagen deficiency, that is what gives that bluish tinge to it. It's not the sclera itself which is blue, it's the underlying next layer that is actually shining through or peeking through, you could say, if not shining through, the thinned out sclera. And this is part of the collagen. I presume that osteogenesis imperfecta, pseudoarthrosis, congenital pseudoarthrosis of the tibia, there are different variants on the collagen thing, also conditions such as Marfan syndrome. So these guys should also be looked at. Osgood's letter is perhaps a bit different. That's one of those range of what is known as apophysitis, like Seward's disease as far as heel is concerned. And Ehlers-Danlos, yes. Ehlers-Danlos is out and out. It's and these widespread collagen conditions should also be checked out for associated problems like cardiac floppy valve syndrome in the and high arched palate, things like that. Yeah. So okay, I think for this case we will plan excision of the pathology site with a nail, telescoping nail. And bone graft kahan se loge? Maybe we can use the fibula. That's a good idea. Yeah, because we'll have to excise a segment of the fibula to get this thing straightened out. So we could use the fibular crush.
Cortical graft support will be there.
maybe like in that form or maybe crushed form, we'll see how it goes, because the kid is a very, you see the photograph, he's so small. I guess one could think on those lines, although
In pseudoarthrosis, it is said that the cortical graft is better than this vascularized graft. The option was initial. Anderson proposed this vascularized graft. He used, but the later on results show that the cortical graft is far better than this vascularized graft. That's why nowadays they are using nail and this Elizaro with grafting.
my logic to that would be that when you talk about routine bony non-unions, one of the most common reasons for a routine bony non-union is devascularization of the fracture ends. It's not always the case. When you get, for example, hypertrophic non-union, it is a stability or lack of it which is the reason for that bone not to heal, fracture not to heal, and that is why in those cases all you need is stabilize it and it should heal, you know. But in atrophic non-unions, it is the lack of vascularity. I mean, congenital pseudoarthrosis of tibia, it's not lack of blood supply. It's something completely different, something to do with the nature of the tissue there. It's almost a focal neurofibromatic defect, which is, so adding vascularity logically should not have a very big impact on that, on that issue. But maybe historically people tried these sort of things out, extrapolating their thought lines from the atrophic non-union, because it looks like that very often. Here it is a it is a cystic spread out appearance, but many times it is the two ends of the bone come in almost like a thin thread hourglass appearance, which what you said. So people equating it with an atrophic non-union probably introduced the vascularized fibular graft. Although I would really tip my hat to the surgeon who can do a vascular anastomosis in that tiny little body, you know, in the sense everything would be so incredibly small that the vascularized tibial graft, first of all to identify that artery and then to anastomose it effectively, to another artery, or at the most it could be that you just keep the vascular intact and shift it here, in which case it would be simpler. If you can identify the feeder artery, take a segment wherein the feeder artery is still intact, and then just because it is just next to the tibia, you just put it there. That might be a bit, it's easier said than done, but I think bone grafting, I would be very reluctant to take from the iliac crest, etc. I think using the fibula would be a good idea. So maybe that is how we should plan it. What is the
Fibula, and sometimes the opposite iliac, tibial tuberosity.
from the tuberosity, the metaphyseal bone machine, you can take some of that out. Yeah. Okay. Good. So get the vendor to bring in the telescopic nail. Put up some articles of surgical technique on our group, academic group, and we'll plan to call this kid in the next few days. Right. Any other topic?
So since there is diffuse osteopenia at the site distal to the pseudoarthrosis site, especially of the ankle joint and the bones in the feet. So do we need to delay the weight bearing or be careful about anything in the post-operative period?
I would think so. I would certainly want to delay the weight bearing in this kid. As such, also a kid who will have a short limb, because no matter what we do, it's going to be significantly short compared to the other side. So with a plaster, the limb will have to be put into in a plaster support, at least to begin with, and given that scenario that you will have a plastered limb with almost 2 inches minimum limb-led discrepancy between the two sides, I don't see how that kid will do any effective weight bearing. So the parents have to be sensitized to that. So not only from the osteopenia point of view, just from the sheer mechanics of the patient not being able to put the two limbs together on the ground would be a reason enough. And then we'll have to tell the parents that they will have to look at a longer procedure of limb lengthening in the years to come. And of course, always counsel in these situations early on that beyond a point, it is beyond our ability as doctors and surgeons to promote that healing part. Loud thinking from my last sort of lecture about osteoporosis and osteogenesis as part of anti-osteoporotic treatment. I wonder whether these kids, I mean, I know these molecules that we will just now discuss are probably not even tested for, so they would not have any US FDA or labeled approval for use in this sort of conditions. But off-label use, would it have any relevance to use anabolic molecules like romosozumab in an appropriate? This is just a thought. I don't expect any answer because there will be no answer based on any data. It will be an answer based on just speculations. So at best it would be an opinion, but it would be worth looking at it. So all that would have to, someone who understands that molecule best would have to look into it. But I am just thinking whether it would have any beneficial effect.
But you are just seeing one part of the body which is osteoporotic. Just the lower limb on the affected side you are seeing and deciding it is osteoporotic. You should see the whole body in total.
Oh, I'm sorry. As far as my introduction of romosozumab or a similar molecule is concerned, it was only with the idea not of osteoporosis as a whole, not fighting osteoporosis, using the anabolic osteoblastic capacity of that molecule to trigger some betterment here at the localized site. I agree with you. It's not. It would be. In fact, I don't think the kid is osteoporotic anywhere else. The very definition of congenital pseudoarthrosis is that it's a localized pathology.
Main two challenges would be, sir, the first would be union at the pseudoarthrosis site. Second would be to prevent the refracture.
Exactly. In fact, whatever osteopenia you see is because the child has not been putting weight on it for a long time now because of the significant deformity.
But one thing is, my basic teaching was the tibia fracture will never unite unless you put weight. If you remember, we used to do the V-nail, where the PTB was given immediately after the surgery on the table and patient made to walk.
You are right. So, Dr. Rao's thrust of his line of thought, which I think has good logic behind it, that osteopenia is one worry that we are having, but that osteopenia, if you want to combat it, then weight bearing is actually one of the ways to combat that. So we'll see how it goes. I think it would depend upon how secure your overall fixation is and how much anti-rotation stability you are able to offer. But we'll keep our mind open on that.
Because refracture is the most common complication in CPT.
A refracture. Having said that, if you have got a solid, strong enough metal strut within that, which is basically this extendable nail, then with that body weight, chances are it will not refracture that quickly. We'll wait and see. Maybe the weight bearing can be.
Telescopic nail is that it grows, expands with age. That's why it will grow.
In fact, I am pretty sure that kids like these will require some tendo-Achilles lengthening in the times to come. So we'll see how it goes. Okay, tentatively we'll plan this for the next week. In the meantime, put up some more articles on the group. We can conclude today's Chai Pe Charcha by just reviewing our case for the day, which is a comminuted lower end radius fracture, 1 week old, in an adult. Having looked at the geometry of the fracture, what do you guys think are the options and which one would you choose?
Because of the presence of comminution, we shouldn't go for an internal fixation as such. We can plan for a external fixator spanning the wrist, which is a process called ligamentotaxis with two metacarpal pins and 2 pins in the distal 1/3 of the radius, and connect the 2 rods, expand, reduce the joint, and then tighten it. And if needed, we can additionally support by K-wires.
Good. Any other?
Very important point I feel is the ulnar styloid is also fractured, and that has to be fixed with a K-wire through it.
In literature, it is always said that
First fix the ulnar styloid.
ulnar styloid and then
Then fix.
So what size K wire would you think will be appropriate, Kshitij? Yeah, I think 1.8, 1.5, 1.8 because thin. Although this guy is a good sized person, so we'll get a better understanding of it when we put because looking at your digital X-rays you can't take any judgment. Digital X-rays can be magnified or sort of reduced in size. So when you put your wire and take a IITV view, now your wire will appear appropriately titrated against the size of that styloid fragment, ulnar styloid fragment, and then you can iterate whether 1.5, 1.8 or 2. What is the worry when you put wire here in trying to impale the ulnar styloid?
Nitrogen TFCC.
no, the nerve.
It's okay. Yeah, I would be worried about the neurovascular. Remember, there is the ulnar nerve goes quite near in this area as well as the ulnar artery. So in putting your wire here and there, if you end up puncturing the ulnar nerve or the artery, you will have a much more serious problem than the theoretical advantage of. Because remember,
Mostly it's a theoretical advantage.
it's a theoretical advantage because all my life I have seen ulnar styloids being pseudofibrotic union there, and functionally the patient has absolutely no problems at all. This forms the 90% of or maybe 95% of the pathology, the shattered lower end radius. If you can get a reasonable realignment of the fragments and realignment of the anatomy here, this little fibrotic union will serve the patient reasonably well. So don't get too carried away by theoretical issues. However, if you think you are very good at your job and you are Arjun himself, and then
It's very difficult.
yeah, because
Tried many times, but it's very difficult.
to get that tiny little mobile styloid process,
You have to open then.
that's overkill. This is exactly what I mean. And you must remember, and the latest out of the college stable is Ashay here. So it takes a couple of years to get it all washed out. The reality and what you would have heard during academic discussions in a teaching institute.
What about the radio ulnar joint?
Radio ulnar joint has to be, so what it means is here, looking at the anatomy of the fracture here, the radio ulnar joint is completely disrupted. So when you pull it out and realign the fragments, etc., if you say that I would also like to put an additional wire across, I would agree with you if it adds any value in terms of stability. If it's a wire that you have put through a hollow space and on the X-ray it looks as if you have caught hold of it, then I would say there's no point. But if it is a wire which actually is able to impale the fragments that form the radio ulnar joint, this is the ulna and this is the fragment of the radius next to it, and if this is a solid enough piece and your wire comes from here to here or from here to there, and it is going to add value, but if it is going through such broken pieces of bone in the radius part of the radio ulnar joint and it is only going to find stability in the dense ulnar lower end of ulna, then putting a wire which goes through a bag of bones in itself will not add value, because the key to this type of fractures, and you would be amazed. Remind me, we run out of time. I have captured that one particular trauma case that I did. A lady from Malawi, young lady. This guy is about 50 years old, but that woman was in her late 30s. So 38 years old, road traffic accident in Malawi. Gujarati, there are many expat Gujaratis living there, and they flew her here about a week down the fracture. And when I saw, crazily enough, whilst the lower end of the radius was more or less crushed, it was like I couldn't see anything in between the articular surface and the distal part except for a dust of bone, not even a bag of bones, it was just dust, they were not pieces. There's no question of doing any K wire, nothing. So I did my external fixator that you just described. Over 8 weeks, the entire, because the periosteum was intact, because the periosteum is a flexible thing, and I had just pulled the construct in a way wherein the periosteum was like a curtain in a good enough position, and the entire bone regenerated. She's doing extremely well. She's a Guju patient. I have those photographs with me. So when you have multiply comminuted fracture, my experience has taught me over the period of time that instead of trying to address it with plating, you saw that range of plates that was available yesterday. Now the industry as well as the vendor as well as gadget boys within our own fraternity they will try to say, no, with this plate I can impale almost with variable angle, multiple hole plates, I can impale almost every fragment that is there. That's stupid to try and do that. When a simple traction will do it for you without disturbing the anatomy, risking anything, So become good at external fixator. The only challenge here, this is very easy. This is subcutaneous. The second metacarpal is subcutaneous. You just have to make sure that you don't take any tendon with it.
We need to flex the joint at the
Ulnar derivation.
This flexion will shift this thing extensor.
The tendons has to be slip. I mean the extensor, actually the extensor expansion is here, but here it's only the tendons here, these two. So tendon को impale नहीं करना है. That is one thing here. And here you have to do graduated थोड़ा stab incision लेके open it up with a mosquito से करके go up to the bone, and then with a sharp self drilling tapping nail just go in and do it. Once in a while you can, depends upon the pins you are using and the diameter of the pins. I would use a 2 millimeter or something dia here on the metacarpal and 2.5 here, and you can do a pre-drill with a K wire and then put your pin in it and allow it to go in. So get it ready.
The radial ulnar joint looks normal, it's not dislocated.
So typically what Asha is saying,
The combination is there and
so let's see. So that fragment which forms the radio-ulnar joint, so the point Vipin is making is that the radio-ulnar joint is made up of fibrous connections between the two bones, right? And that particular fragment is as such as is still joined with the ulna. The moment you stretch it out, it will look much better. And in the past I have impaled the radio-ulnar joint with a horizontal wire. And my point to Asha is that it can be done, it should be done, it can be done. The only reason why I am saying don't be over enthusiastic is if you impale, I am going to ask you a question. If you impale your radio-ulnar joint with a K wire, what is it that you will have to be very careful about then? Once you do it, you have done it. I mean, I am not asking about impaling an artery or anything. That's all done. You have done a safe job of putting a wire through from here to here, avoiding the radial artery, the ulnar side. Having done it, what else is now the issue that you have to keep in mind? Any of you? Yeah, pronation, supination, it will break that wire and then you are in deep trouble.
That doesn't make sense because if we are putting a K wire, we are anyway going to immobilize.
So that's where I am coming. Now if you have not done it, then you don't need to necessarily immobilize the elbow. When my external fixator is just here and I have stretched it to length and my x-ray shows that all the fragments are well aligned, I have no reason to put that patient in a above elbow cast. And as long as I have not gone past this, those tiny movements that inevitably happen, no human being can keep a forearm immobilized like this and not go into these little movements. So if you are going to impale that radio-ulnar joint, then you better put a solid prevention of pronation supination, which you will not be able to do in the form of a cast. It will be a plaster slab, but even then it will have to be something that the patient doesn't keep on doing that within that plaster slab.
So we are talking about two surgical treatment. One is with K-wires and the other is with external fixator. So in an external fixator, the principle is ligamentotaxis. So we are not putting K-wires at all in the joint. But if we are using K-wires, we are putting it into the radius, and for that matter, we will immobilize.
Oh yeah, then you are absolutely right. Agree. If you are going to use K wires and then you put an additional wire stabilizing the radioulnar joint, whether you do the radioulnar joint K wiring or not, you are anyway going to put it in a plaster cast, and then I agree. I was thinking about combining the external fixator with this. Yeah. Good. So I think we have had a good discussion on this, and one of the things which I would suggest we can end up doing as part of this academic series of lectures is to pick up cases like these and keep on discussing it besides the didactic lectures which I am giving you guys. Okay, good. Let's start work for the day. Thank you.